Hello and good evening. My name is Professor Robert Boy. Our moderator, Dr. Andrew Baird, has just had a technical problem. He was on for the last 20 minutes, so I'll get started anyway. So we've got a 1-hour program. I'll speak for about 40 minutes and there'll be 20 minutes for questions. It's a real pleasure to be with you to speak on the topic of meningococcal disease, an update on epidemiology, including prevention. Next slide, please. So that's my bio. If you just look at the first 2 sentences, I'm an infectious diseases pediatrician and epidemiologist. I'm currently a senior professorial fellow at the University of Sydney's Children's Hospital, Westmead Clinical School. And it's my pleasure to acknowledge the original owners of this land and to pay my respects to elders past, present, and emerging. Next, please. So our housekeeping, type your questions in the Q&A, please, not the chat. And there'll be a very short survey near the end as the event is closing, and we'd love to get your feedback. A recording is being done. It's in operation at the moment, and the slides will be available on the website within a week or so. So without further ado, the issue of meningococcal meningitis and septicemia is an old one. This paper was published over 60 years ago, and it looked at meningitis in Africa. Next slide. And the African meningitis belt was described going from east to west below the Sahara Desert, and a wind would blow off the Sahara Desert called the Sahel, and that would blow dust into people's faces and throats, damage the throat, and allow a colonizing meningococcus to go into the bloodstream to cause meningitis and ultimately septicemia and also meningitis. The biggest outbreak we're aware of was about 250,000 cases nearly 30 years ago with 25,000 deaths. And at that time, meningococcal A dominated in Africa. Since then, A and C and W have all been a concern in Africa. But let's talk about Australia, because that's going to be the focus of my talk tonight. Next, please. Meningococcal disease is always in the news. Last year, there was a case in Victoria that got the headlines in New South Wales. And only last week, there was an announcement from Queensland that they are starting a Meningococcal B vaccination program with free vaccine for eligible infants, children up to age 2, and adolescents from 15 to 19. I'll comment a bit more about those ages in a while. So that's the exciting news. It's only been published at the end of last week. Next slide, please. The program is said to be implemented in full by the end of March. I think it'll be a bit slower than that, but it will be a quick introduction. Vaccine deliveries are said to be starting already. As you know, children under 2 who are Indigenous, Aboriginal and Torres Strait Islanders already receive free vaccination against meningococcal B and through the National Immunisation Program. And the new program in Queensland will make the vaccine available for infants, children and adolescents, in addition to other eligible groups. Currently, the vaccine is available for purchase on the private market in Queensland and throughout Australia. And they emphasise that it's important, if you have questions, to ask your GP. And so I hope to be able to have answered all your questions from nurses and doctors by the end of this evening. When you look at meningococcal B uptake under the private market, only about 5 to 10% of children are getting vaccinated. But I do know the occasional enthusiastic GP who truly is achieving over 75% uptake with the vaccine through explaining it clearly to their patients. And but that GP in particular that I'm referring to had the unfortunate instance of a young lady in her 20s, too old to have been vaccinated from 20 and above, who developed meningococcal B only last year and died of it. So the irony of the missed case, not the GP's fault, but how the system works. The university student was away from home. She caught the infection, it developed into disease, and tragically died of it. The young lady's name was Arabella Fiddler, and her parents made representations to the Queensland government and in particular the Health Minister, Shannon Fentiman, and with the help of the Meningitis Centre of Australia, they raised the awareness and understanding of meningococcal B, how deadly it can be and how devastatingly quick. And as a consequence, you see now the Queensland meningococcal program only 6 months after the meeting that they had last year. Next slide. So infants can start from 6 weeks of age, and the first dose should be given before 12 months of age. But catch-up vaccination can be given between 12 and 24 months of age. Adolescents are being vaccinated between the ages of 15 to 19. It's interesting when you look at the epidemiology in Australia of meningococcal B, about a quarter of cases occur in children less than 5, another quarter occur in 15 to 19-year-olds. But about an eighth, a significant other group, occur in 20 to 24-year-olds. So that if you can't get it free for them, it's a good idea to consider them being vaccinated on the private market. So once vaccination is commenced during the eligibility period that's coming up, a person can get their second dose within a month or even a year, regardless of their age. Over 80% of meningococcal cases in Australia are due to meningococcal B, and in the two key age groups, under 5 and 15 to 19, 90% of cases are meningococcal B. The highest rate recently has been in Queensland, and hence that may have influenced their decision. Some 7 years ago, they decided to introduce meningococcal B vaccination for all children and teenagers in South Australia. And at that time, they had the highest rate. So certainly epidemiology influences decisions. Next slide, please. This is a letter written at the end of last year in New South Wales by the parent of another 23-year-old who got severe meningococcal disease, but happily did survive. This is Lily, known as, her full name is Lily O'Connell, and I'll show you a photo in a moment. But her mother begged the Health Minister, Ryan Park, to consider meningococcal B vaccination in New South Wales. If you look at just the highlighted things, in the third paragraph, for 3 days, whilst in intensive care, there was no assurance that Lily would survive. And the last sentence, her mother has written on multiple occasions and produced material, video campaigns for vaccination awareness. Next slide, please. So as she said, prevention is the best hope. Lily lost both her kidneys, and she only survived because her older sister gave her a kidney transplant. Lily has since been the face of New South Wales' annual meningococcal campaigns. And as I said, I'll show you a photo of Lily in a moment. Next slide. There's Lily on Christmas night when she had petechiae from meningococcal W. Only 8 hours earlier, she looked fit and well and healthy, as you see in the photo in the yellow. So an extraordinarily, devastatingly quick onset, and she was very much in peril of her life. Next, please. So what's the situation in Australia right now? Well, as I've said already, the most cases have been in Queensland last year. This is the most up-to-date data we've got. There were 144 cases, bottom right, 144 cases in Australia last year. 111 of 130, because 14 were not grouped, 111 of 130, over 80% were B. Whereas a year ago, look at the bottom right of the slide, 127 cases, fewer were in 2022. And in 2020 and 2021, for the first time ever, there were less than 100 cases each year in Australia. So meningococcal B is by far the most common cause of meningococcal disease in Australia. Next slide, please. So I like to say the world has changed, keeps changing, but some things stay the same. South Australia introduced the vaccine 6 years ago, and they've been successful. The vaccine has demonstrated sustained vaccine effectiveness against invasive disease. And interestingly, There's also been prevention in about 30% against gonorrhea, a related Neisseria organism. Now, if we look at what happened in the UK, where I spent 15 years doing research on meningococcal and Hib meningitis, meningococcal B went away during social distancing in 2020 and the first half of 2021. But then they sent their university students back to university, halls of residence, crowding, all the things that you imagine that they do, parties and so on. Meningococcal B started to come back. So if you look at the third dot point, meningococcal rates were at a historic low until they went back to university, and Australia's were also very low, as I said. There was a stark increase in the UK in meningococcal B cases in teenagers and young adults, especially in university students, when they started mixing again. Next slide, please. So the more things change, the more they can stay the same. While working in the UK in the late 1990s and the 2000s, with a team of researchers, we performed a risk factor study in survivors of meningococcal disease who were teenagers, nearly 150 of them. We published the work in the BMJ in 2006, and the key risk factors, the second dot point, were having a previous flu-like illness, being a student, school or uni, having multiple kissing contacts, what we called mouth kissing or French kissing, and exposure to smokers, not the smoke, but to smokers who would cough and would transmit the meningococcal bacteria through the air. Now, what's interesting is that we knew about this from a publication in the BMJ in 1918 at the end of the First World War, which looked at the epidemiology of meningococcal meningitis, and those risk factors were being recognized way back then. Having said that some things are predictable, there are also some things that are unpredictable. Next slide, please. In Australia, during both world wars, we had huge surges in meningococcal disease, both due to serogroup A. But since the 1970s, it has virtually disappeared. The best theory is that improved socioeconomic status with less crowding has been the explanation for why meningococcal A has almost disappeared, hardly ever occurs in Australia. So some people have asked, why might meningococcal B not disappear too, as crowding decreases and socioeconomic status changes and hopefully improves? Or might a vaccination program against B help to get rid of meningococcal B disease, or at least restrict it in those who are vaccinated? Now, there's an interesting point here. The South Australian research, a marvellous piece of work led by Professor Helen Marshall, an Australian of the Year for South Australia a couple of years ago, did a cluster randomised study of high schools. So one high school got vaccine, 1 year everyone were offered it, and the next year the other group of high schools were offered the vaccine. And they looked at whether the vaccine influenced carriage, colonisation, whether infection in the throat, not disease, could be reduced by vaccination. It was called Be Part of It, Get Involved. And unfortunately, although ultimately they showed very strong protection against disease, the vaccine, the meningococcal B Bexsero vaccine, did not prevent colonisation. It didn't prevent carriage, and so transmission could still occur. Next slide, please. So this is looking over almost a century of deaths from meningococcal disease. So First World War, Second World War, huge rates, and then the 50s, a lower peak, and then again at the end of the 90s, another peak. So very interesting. Those early peaks before the 1970s were just about all meningococcal A, but beginning in the 90s, meningococcal B and then meningococcal C also led to increases. Next slide, please. So this is a little bit complicated. Just look at the graph on the left. You can see we pick it up from 2005 and then go into 2020. And we see that meningococcal B, after peaking around 2000, gradually went down year on year on year. And in 2003, because meningococcal C had also peaked, a vaccine had become available and was introduced, and it's now been used in Australia routinely for 20 years. And that led by the 2015 to a 99% drop in C. But curiously, Meningococcal B also declined, in fact, by about 70%. So it was a dramatic decline in B disease without a vaccine. So something else was happening. The bug had changed, immunity in the population had improved for some other reason. It's not clear. But if you look to the right-hand side of the graph, you see a blip in 2007. And I want to talk about that a bit more. In 2006 and 16 and 17, 4 different serogroups increased all in 1 or 2 years. An interesting occurrence. And by 2017, for the first time ever, meningococcal W was slightly more common than meningococcal B, although within a couple of years, B had resumed its supremacy as the most common. Next slide, please. So if you look at invasive disease and laboratory data, they track each other very closely. And you see again that peak in 2017. Next slide, please. And I asked the question, why would all 4 serogroups show a peak in 1 year? Normally, way back in 2000, when meningococcal C was a special problem, there was a clone, a special virulent, more invasive clone, which appeared around the world, affected the UK as well. And that clone was the cause of that surge. But for 4 different serogroups to surge is a bit strange. And so what do you think? Next slide, please. Well, in 2017, there was a surge of influenza. And it's well recognized now that influenza predisposes to secondary meningococcal and pneumococcal infection, but importantly, meningococcal disease. And you can see on the right-hand side that influenza A H3 peaked in 2017. And that's coincident with the rise in those other 4 serogroups of meningococcus. Next slide, please. So if we break it down, if you look at 2013, before the surge happened, the meningococcal B vaccine was first licensed and registered in Australia, but it was not adopted. It went to ATAGI and to PBAC, and they rejected it, and they rejected it a further 3 times in the next 10 years. But then if we look at the peak of 2017 of disease, we can see that a quadrivalent ACWY vaccine was introduced. And within another year, it was given to toddlers routinely. And B vaccination was introduced for just high-risk people. And then within another year, the quadrivalent vaccine was introduced routinely in 2018 in all states of Australia for teenagers. So the peak was in 2017, then there was a rapid decline. So were all these vaccines the reason for the decline, or did the disease go away of its own accord because there was much less flu around? Well, clearly there was much less flu around, but vaccine was being implemented. So perhaps both reasons could help to account for that rapid decline in meningococcal disease. Next slide now, please. If we look at what happened between 2012 and 17, meningococcal W, as I said, went up rapidly. It was a new clone. It went around the world. It was more invasive. It was more nasty. It was more deadly. And it rose rapidly in numbers, so that by 2016, 17, some states of Australia, like Queensland, started to introduce the meningococcal W, or the ACWY vaccine, for teenagers. And you can see that in 2017, the only group where the numbers were not going up but actually went down were 15 to 19-year-olds, which was the group who had been offered vaccination in a couple of states. So that's ecological data. That's association. It's not clear proof, but it's interesting. Next slide, please. So Greg Hunt said that every state would have vaccine, national introduction. So 2018, all teenagers got it. Next, please. And immediately there was a drop. So once again, was it because flu had gone away? And I think that's a big reason. And was it also because of an influence of vaccination? Well, it went down in all age groups, not just in the vaccination age group. So I think the flu explanation of going away in 2018 is a better a better understanding of the situation. Next slide, please. So I'm coming up to the 2020s now. When we look at MenC conjugate vaccine being introduced 20 years ago, we see that there was a lot of disease, but rapidly the numbers went down. And by 2016, if you look at the right-hand side, we published a paper from the National Centre with Glenda Lawrence and Monica Lara from the National Neisseria Network, and we showed there'd been a 99% reduction in meningococcal C disease. But at the same time, there'd been more than a 50% independent reduction in meningococcal B disease, against which we weren't vaccinated. So again, this is an ecological association that may be explained by a number of factors, but not seemingly vaccination. Next slide, please. So in 2022, less than 2 years ago, we published a paper looking at the large decline in meningococcal disease in Australia. We called it the silver lining of the pandemic playbook, the fall of disease and influenza, both in the time of COVID. And we explored reasons for this reduction. And clearly immunization was important, but also the social distancing, which led to influenza becoming very rare during the winter for once in many, many decades, because of COVID restrictions, was an even stronger explanation. Next slide, please. So the Medical Journal of Australia and the Sydney Morning Herald both reported the same thing. We've never seen this before. Common illnesses, not just COVID, not just flu, not just meningococcal, but many infections were wiped out in the fight through social separation in the fight against COVID. So that hit the news. Next slide, please. And it illustrated the power of social separation. Now I want to talk about the impact of vaccination on carriage. The B part of its study I've briefly mentioned already from South Australia, remembering that they had the highest rate of disease, and most of it was MenB, and half of it was in teenagers. So they did this high school research to look at the impact of the vaccine, and as I've reported already, it did not reduce carriage of meningococcal B in South Australian high school students. Next, please. But what it did do, the power of vaccination on disease, not carriage, was to prevent disease. Both vaccine effectiveness and vaccine impact were very clear. So it was a state-funded program for infants, children, teenagers in South Australia beginning in 2018. And if you look to the third dot point, a reduction of nearly 2/3 and nearly 80% in the incidence of disease in infants and adolescents, respectively, a major reduction. The 2-dose vaccine effectiveness, if you actually had been vaccinated, was over 90%. And interestingly, if you look second from bottom, 2-dose protection against gonorrhea in teenagers was 33%, a very nice side benefit. So the extra protection with the 4C MenB or Bexsero vaccine from gonorrhea should be considered as part of analyses by PBAC and cost-effective analyses too. Next, please. And if you look at the bottom point, the last sentence, vaccine effectiveness with at least 1 dose was 64% against serogroup B disease. And here's another interesting other kind of finding. Over 80% protection against non-serogroup B disease. That was statistically significant. And one possible explanation for that is that the 4C meningococcal B contains components which are common to all meningococci, not just meningococcal B. One component is purely meningococcal B, but 3 other components may be found in other serogroups. So that may be the explanation. And yet another side benefit of routine use of the meningococcal B vaccine in children and adolescents. Now that's Spain. I'm not going to show you data, but there's similar data from Portugal, from England, from Canada. So there's a lot of data accumulating, and now 45 countries, the vaccine is licensed and being used. Next slide, please. So going back to our work in the Medical Journal of Australia, published 2 years ago, what we were able to show very clearly, and Rob George, a microbiologist, led this work, was that peaks of meningococci in a particular month coincided with peaks of influenza in a particular month. So a nice piece of ecological association, but a lot of peaks running together. And the same has been shown in the United States and other places as well. Next slide, please. So both influenza and invasive meningococcal disease are diseases of crowding. We know that. But those two have a special relationship. So it's more than just the fact of crowding. It's more than that. The observations from a century ago in military outbreaks showed the impact of overcrowding on meningococcal disease and the effect of simple public health measures to allow distancing where people slept, for example, to improve the hygiene of their circumstances. So that 1918 paper, which I referred to earlier, showed 6 predisposing factors. And if you look at the third dot point, they were the season of the year, like winter. An epidemic of influenza was recognized even then. Overcrowding and high carriage rates. Next slide, please. So the practices and the policies of vaccination in Australia, and as they relate to rates of invasive meningococcal disease, are interesting. So we've had routine meningococcal C vaccination since 2003. From October 2018, we got meningococcal B for some particular high-risk groups who were eligible. And that included Indigenous kids, but the only state where all children and teenagers were offered vaccine was South Australia from 2018, Indigenous children from the middle of 2020. And so the practices and policies of vaccination against meningococcal influenza had an impact, but there was also a very big impact, in my opinion, of social distancing during the pandemic. And clearly also we have seen in many studies from around the world that flu infection influenza, specifically influenza, is followed by meningococcal disease. The number needed to treat, you probably have to vaccinate hundreds of thousands against flu to prevent 1 case of meningococcus, they estimated in the UK. But COVID, another viral infection, was not nearly as often followed by bacterial infection. And we can go into the reasons for that later. Next slide, please. So the lowest rates ever in 2020 and 2021 of invasive meningococcal disease and of influenza since national records were kept. I've made the point. Next slide. So 10 years ago, the vaccine became available. It was registered for children from 2 months of age, and available by private prescription from 2014, 10 years ago. ATAGI said it would be best used in under 2-year-old and 15 to 19-year-olds. And the PBAC felt that it wasn't cost effective and rejected applications. Next slide, please. So this new program that's starting this year in Queensland, meant to be implemented next month. The third point, the program will make meningococcal B vaccines available for infants and children up to 2 years and adolescents between 15 and 19. I've said already of the important advocacy work done by charities, especially the Meningitis Centre. And also I want to pay credit and homage to the bereaved and affected families who have had severely affected children or actually been bereaved and lost children and young adults in their family, like the Fiddlers and the O'Connells in Queensland, who met less than 6 months ago with the Queensland Health Minister. Next slide, please. This is a bit gory. It's the leg of a child that we looked after at Westmead, a young child of 2 or 3 with meningococcal disease. And she had gangrene of her toes. She needed major skin grafting. And when you have such severe shock which produces this, it also affects the growth plates. So it can kill off part of the growth plate, but not the whole growth plate. And so you can get unequal growth and curving of legs and arms, which require orthopedic intervention for the next 5, 10, 15 years. So you can see complications here in the slide, but there are also hidden complications that may not come out for 5 years or more later. So governments need convincing that not only is there short-term benefit in preventing meningococcal B, but there's medium and long-term benefit as well from vaccination of children. Next. So parents need convincing too of the value of vaccination. I've mentioned Dr. Lisa Beecham on the Gold Coast. She's developed a tool for GPs to use on their desktops. If you want to look at the slides later on, you can get that website, or you can take a photo on the screen. I'll leave it there for a few more seconds. She uses something called Primary Sense. Primary Sense is the tool. And they have evidence that a point-of-care approach where GPs get reminded that someone is due for a vaccine are likely then to act on that and recommend a vaccine, and the vaccine then is often given. So the journal AFJP has got an article on it, and as you can see, there's a website there. Next slide, please. So once you've got parents convinced and you get children vaccinated, they do have high levels of protection. There are other issues that go to why governments and PBAC make decisions. That's listed on this slide. I don't have time to go through them, but if you want to go back to the slides in a week's time and go through these particular points and email me about any questions, I'd be happy to answer them later on. Next slide, please. And likewise, there's these other issues which are a bit technical, but they come down to the fact, in simple terms, that in Australia, we value medications which have immediate benefit against vaccines which have postponed longer-term benefit. And that's the sum of it in my opinion. So how do we, in the last slide, the last sentence, how do we improve the health technology assessment process to get a more accurate cost-effectiveness reflection of vaccines? Next slide, please. So we made a video with this young lady who had meningococcal B at the age of 16, and she came back from that to become a Olympic wheelchair racer. Resilience triumphing over adversity. If you want to see the video called Doctoring Little Mermaid, it's on the Immunisation Coalition website. Patient advocacy is really important. This young lady, who's now got 3 children, and this is now 25 plus years since she was ill, has done really well. And she led one of the charities, Meningococcal Australia, for several years. Next slide, please. I'm just going to conclude now. In summary, I think there's been so many fascinating twists and turns in meningococcal epidemiology in Australia for over a century. MenB has been, for the last few decades, the commonest cause. Apart from a blip in 1 year in 2016, it is preventable. In 2022 and 23, it accounts for 80 to 90% of cases in less than 5-year-olds and 15 to 19-year-olds. We've had a licensed vaccine for 10 years, and that vaccine may also be protective against other germs. There is another meningococcal B vaccine for children aged at least 10 years, and that too is available on the private market. And interestingly, as of only October last year, the US FDA and the CDC Immunization Committee approved a new vaccine, a 5-in-1 for 10 to 25-year-olds against A, B, C, W, and Y. So it's a combo vaccine of conjugate A, C, Y, W, and a B monovalent vaccine delivered in the same vaccine. It's wonderful to see that Queensland has followed the example of South Australia in beginning to implement this month and next a new meningococcal B program. My final slide are some pictures. Next, please. So there's Lily since she recovered and after her kidney transplant, but sadly Arabella Fiddler on the right died of her disease, and her parents have worked very hard to raise awareness and raise the pressure on government to make vaccine more available. Next, please. Thanks very much. And if Andrew's back, I'll pass to him.
Yes, thank you very much, Robert, for an excellent presentation. Thank you for such a challenging and informative and provocative even presentation. Many thanks, Robert. And thank you to our attendees who have submitted questions. We've got about 10 questions. It's unlikely that we'll be able to work through all 10, but those that we can't address this evening, we will look at, and we'll provide the answers on the website in due course. So, Robert, are you up for some questions?
Yeah, I can start with the first one.
Okay, well, the first thing I'm going to ask about is should meningococcal vaccine, should we be offering it to other age groups other than children over 10 on a private prescription if they've been vaccinated as infants and toddlers?
We have data from Oxford, where in fact I used to work 20 years ago, to show that meningococcal B vaccination in the first year of life doesn't produce very long-term memory. You have to have been vaccinated over a year of age to have memory which responds to a booster 10 or more years later. So certainly I think that protection does begin to wane after 5 to 10 years. So booster, even if you've had a vaccination in infancy before a year or before 2 years of age, if you're now suddenly 15, 12, 13 years later, I think a booster vaccination would be appropriate.
Thank you very much, Robert. In fact, you've answered two of the other questions as well, which were around how long does the immunity for meningococcal B vaccine last, and I think you've answered that very clearly. Looking at correlations, we have some questions around what is the correlation between influenza and meningococcal disease, and also a speculation, is this a post-influenza complication?
Yes, it's very clear that, for example, when we did our study in teenagers who'd survived, in the week before they got fast-moving meningococcal disease, they had an upper respiratory tract infection with a sore throat, a cough, perhaps a fever, which went for a few days, and suddenly they got meningococcal B. And what I explain that by is saying that the influenza infection makes the throat inflamed. It allows a commensal, a colonizing bacteria called meningococcus to invade, go into the bloodstream, and thereby then to cause septicemia, meningococcemia, and then from there to the brain even to cause meningitis. So I think it's an event that one occurs 1 week and the next can occur the following week. And I think the clinical experience, the research experience, and the ecological work on incidence of peak months all point to influenza predisposing to a secondary meningococcal infection and bacteremia. There's a question here, given the high rate of disease in Queensland currently and the evolving epidemiology with people crossing borders, going on vacations and doing sports interstate, should we vaccinate more people and look more closely at cost effectiveness, as spending a week or a month in intensive care is a very expensive exercise? Well, actually the PBAC do that. They do very careful analysis of the acute hospital costs. What they don't tend to include is societal costs. Let me give you a couple of examples. There's a charity in Western Australia called the Amanda Young Foundation that's done a fantastic job for over 25 years. And it's in honour of a teenager from Perth who went to Sydney for a sports event, a rowing event, and she developed meningococcal disease while on coming back from Sydney. And so sporting events are associated with meningococcal disease. and that's worth taking note of. There are not a lot of sporting outbreaks, but they're certainly well described, and teenagers do go on major sports events, and vaccination, I think, is a very helpful thing for them. And if you can do it on the private market, that's just one more way of protecting teenagers against some of the diseases that you are more likely to catch in the late teenage years. Someone asked, if you vaccinate against flu, can you prevent meninge? Well, possibly, but as I said, also way back in the 1990s, some colleagues that I worked with in the UK looked at the fact that you had to vaccinate hundreds of thousands to prevent one case of meningococcal. So you vaccinate against flu to prevent flu primarily. You will get a secondary benefit, but it's not a big one. You can't put MenB vaccine on the NIP for everyone. You have to draw a line somewhere. It is an expensive vaccine, and the government is currently spending, in Queensland alone, the new program is costing hundreds of millions over the course of the next 4 years. So you can't offer MenB vaccine to everyone. There are definite risk groups. The biggest risk group is at about 4 to 6 months of age, after maternal antibodies have declined. But teenagers 15 to 19, and as I said in my talk, about a quarter of disease is under 5 years of age, a quarter is 15 to 19, and another eighth is in 20 to 24-year-olds. So were we to expand meningococcal B, we might offer it also to people in their early 20s, but for the moment that can only be done on a private script. Just looking through. How much does meningococcal treatment cost? It can cost a lot. Someone's put in some figures there, RL, if you want to look at the chat and put a number of numbers. Can I also make the point that Eliza, who led the Meningococcal Australia charity for several years, who had disease over 25 years ago, she only recently had a complication with pus coming from her stump, and it was discovered that a stitch from 25 years ago had been left behind, and recurrent episodes of infection and pain and protrusion of pus over many years repeatedly was found to be a complication of the original operation to treat her gangrenous lower limbs, which had been removed. So, you know, these things are scary, and there are many things that should be included in the cost, including medical things in the longer term, and also including a better understanding of the social cost. So someone's put a lot of data in here, so I feel free to read it. Okay, Gemma Sheehan asks, what's the length of protection from a full primary course of Bixero? So the studies that have been done looking at immunogenicity showed that even 10 years out, there's still better antibody protection in vaccinees compared with non-vaccinees. But as I've mentioned already, the Oxford study showed that children given vaccine before 1 year of age are more likely to need a booster. So this says a child completes the course at age 5. Can they have another course? I've answered that. Liz Green, is it best practice to recommend MenB and Men ACYW from 6 weeks? That raises a really interesting issue. When I came back from London to visit 20 years ago, when I was still working in England, the decision had been taken in 2002 to introduce meningococcal C conjugate vaccine as a single dose at 12 months of age, whereas in the UK it was being given from 6 to 8 weeks of age. It was being given to infants from 6 to 8 weeks. The epidemiology drove those decisions. Let me explain. In the UK, there was a lot of disease in children under a year of age. Indeed, a quarter of cases were under a year, and another quarter were 1 to 4 years of age. Whereas in Australia, there were only a handful of cases each year in under 1-year-olds of meningococcal C back around 2000. So they took the decision to implement a single dose vaccine from 12 months of age. So that's why the UK was different to Australia. We have virtually no meningococcal C disease now, so there's very little meningococcal Y or W. Well, Y occurs mostly in middle age and older people, but W can occur in young infants, but there are very few cases of W now. It's gone away to vaccination. At a year of age and at 15 years of age has not only direct benefit to the vaccinated child, but also an indirect effect. The conjugate vaccines against ACWY actually do prevent colonization and transmission, whereas meningococcal B don't prevent colonization and transmission. The conjugated ACWY do, and so the benefit extends to other age groups because they don't having been vaccinated, they don't transmit colonization to other children. Trying to keep, Kath Jemison said, pilgrim trips to Saudi have a legal requirement for men ACWY. Yes, that's right. Have we identified events in Australia that have shown a peak in case numbers, events that could help promote vaccination? Well, let me tell you another interesting story. 2 years ago, we had Splendour in the Grass in New South Wales around Byron Bay. We had an outbreak of 4 cases of meningococcal B disease. The local public health specialists and nurses made a special inquiry to see how these 4 cases might be linked in any way. They'd all been at the concert, the event, Splendour in the Grass. And the really interesting thing was that we also ensured that the bacteria which had been found by PCR or culture were sent to the National Neisseria Network laboratory in Sydney run by Professor Monica Lara. And they, with other colleagues, ascertained that the meningococcal B events were not the same bug in each. They were a different genotype. They were not the same, which indicated that there had not been transmission at the site, at the event from one to another, but that there had been multiple transmissions, so that 3 or 4 separate events of different meningococcal B genotypes had led to disease. Fascinating. So that's why you do quality epidemiology. That's why we rely on our public health colleagues, and we rely on our microbiology colleagues to do clever work in the way of shoe leather, and in the way of in the laboratory. Someone anonymous asked, you showed and commented about cross protection for other meningococcal strains. Is the same true of the other meningococcal strains, that is off-target protection? Well, I'm only aware of the work with Bexsero in infants and teenagers from South Australia and from Europe, which there are 3 or 4 studies now showing about a 1/3 reduction in vaccinated people against a gonococcal infection. The study from Spain, I haven't seen that replicated. It may have been, I haven't seen it replicated. So that's speculative and it needs further inquiry. So the study from Spain, they used meningococcal B Bexsero and they saw benefit in the way of C and W disease also. So that's best I can answer that. Sonia is asking, should we recommend Bexsero for travellers? Okay, so the epidemiology, I started by showing you Africa, where travellers like to go, but it's essentially meningococcal A, C, and W infection, and sometimes even one called X, which people haven't heard much about, but they even have X in Africa. But B is not an issue in Africa. However, if you're traveling to first world European, North American places where meningococcal B is also an issue, including people who go to Ireland and England and Canada, etc. it is something worth considering, having the meningococcal B vaccine.
Robert, should we be recommending that all people aged over, for example, 29 get vaccinated for MenB and for ACWY? Just being aware of the risks in middle-aged adults and being aware of the answer you've just given that you've not had it yourself.
You know, honestly, people over 30, the risk does decline. It's still there in your 20s, but in 30s and later, the risk goes down. There's a small rise again in older people, but not a big rise. And so in the main, I don't think it's a big enough risk, and I don't think it's cost effective.
Sure. We were talking earlier about associations. We talk about influenza and gonococcal disease and COVID disease. Have you spoken about the COVID association with IMD?
Only indirectly. What I would say very clearly is that from the very start of COVID, I followed the public health situation and the publications online, and there was really very little evidence of secondary bacterial infection occurring after COVID. There was some rare bacteria in diabetics causing necrosis and disease in the neck, but honestly, there's very little secondary bacterial infection that I saw occurring after COVID.
Yeah. And this question is around maternal antibodies. So I'm assuming that this relates to a mother who has not been vaccinated. But what about an unvaccinated mother passing on maternal antibody to her baby? Does that happen?
So yes. So most adults, by the time you're an adult, you've been a carrier at least once or twice or thrice, and you've got antibody in your blood and T-cell immunity too. But that antibody in your blood of a pregnant woman does get passed across the placenta and does provide protection to the newborn baby. But actually that protection only lasts for a couple of months. And from about 2 months of age, the risk of meningococcal B especially rises quite rapidly. So you're only protected for a couple of months, and then that's why vaccination starting at 6 to 8 weeks is a good idea.
Yeah, because the protection is very temporary. That makes a lot of sense. And a question I'm going to ask, which was submitted by an anonymous attendee, is, and again, we're talking on this age topic, the upper age limit, and what about healthcare workers?
Yes, healthcare workers are surprisingly not at great risk. Way back 20 years ago, we reviewed the literature on this, and in the UK, we could only find 3 cases in reports. One a nurse, one a doctor who did an intubation, and one an ambulance guy. So since then, there have been occasional reports of healthcare workers developing meningococcal disease. And certainly, you know, we've learned a lot about using personal protective equipment during COVID. Meningococcus does sit in the throat. It's not a genital infection. It is a throat infection. It is made worse by being a smoker. Smokers carry more commonly and cough and transmit more commonly too. So that's worth knowing. But healthcare workers, what we used to do, and we managed hundreds of cases at St Mary's Hospital in London over the course of the years. For the first couple of days, we wore a mask around patients in the intensive care, but they usually had antibiotic killing of the organism within a couple of days. So healthcare workers, surprisingly, are pretty low risk from what I can tell.
Yeah. Thank you, Robert. Very useful advice. And I think this will be our last question, because we are just coming up to the sort of the 7 o'clock mark. And it's actually a question, is a sort of a mathematical question. It's about relative numbers and absolute numbers. So the question is, the proportion of total IMD cases that are MenB have increased in recent years, but the actual number of MenB cases seems to be largely unchanged and similar to pre-COVID levels. So the question is this a matter of serogroup replacement in the context of successful vaccination for ACWY, or is there something else going on?
Oh, well, there's a very big question with a lot of elements and a lot more explanation than the time I've got. But I'd say simply that what I clearly showed was that the rate of meningococcal B disease has fluctuated widely, and it was very high around 2000, and it came down to a nadir in 2020, under 100, 127 in 2022, 144 total cases, of which 85% were B in 2023. So currently we're on an upward curve. We've gone from under 100 and 100% increase to 144 in 2 years. So it's certainly not same as. There's an ecological niche in the throat, and if there isn't a meningococcal B there, C there, then perhaps B can fill that niche. I'm not an expert on the microbiology, but that's certainly a possibility. I expect us to have another moderate season of flu at least this year, and so I expect us to see perhaps over 150 meningococcal cases this year. It's not a lot, let's be honest, but it's devastating. It's so severe. 5 to 10% death rate and a 20% severe morbidity rate affecting the skin, the kidneys, etc. So I think I better leave it at that.
Thank you very much, Robert. Thank you, and indeed, thank you very much for the presentation and for the responses to the questions. A very salutary and inspiring presentation, helping us with our knowledge and understanding around this topic and inspiring us to think MenB and to do what we can to reduce the burden. Thank you very much to the attendees for being here this evening, and to those who submitted questions. Questions that have not been answered, and I think we did pretty well to get through them, will be answered and the answers will be placed on the website. Our next webinar in the update series is on HPV and is on the 13th of March. And that will be presented by Angela Newbound. Please remember, subscribe to the Immunisation Coalition newsletter and the conference alerts. And please follow us on the usual social media to get updates on infectious disease information. Everyone, many thanks, good night and stay safe. Thank you.